Okay, we might get going. Good morning, everybody, and welcome to the last day. And before we start, I would like to pay my respects to the traditional owners of the land on which we sit today, which are the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and future. So welcome back, everybody. It's been a fantastic few days and week for all of us, I think, certainly for us as the organisers. We've really enjoyed it. And so I'm going to just summarise or recap really what we've briefly, not to be an exclusive list of things of what we've sort of talked about so far, but we had but just have a bit of an overview of what we've done so far. So in our side session, the first at the beginning of the week, Natalie Cavajo and Mark Jitt held some side training on vaccine economics and infectious disease modelling and health economics. And so that was fantastic. And that was with Spark and Spectrum, yes, thank you, support as well. And then we kicked off with our formal session on Wednesday, focusing on our early career researchers. And we had a fantastic talk by Professor Etob and also by Dr. Senjuti, which really set the scene, I think, for our 3 days and how we should, approach global health and the thinking and how we support, from our point of view, how we support countries and responding to their needs. So we had a really fantastic session there, and Professor Etob brought forward the idea of the vaccinology and ASEAN Pacific vaccinology work and also potential for, even partnerships through manufacturing and pool procurement mechanisms possibly for the region, particularly for emergency use vaccines. And then we had Dr. Senjuti, who sort of talked about what her evolution over a long time, these things take a long time, but how the thinking has changed and how the circumstances have changed and how the capacity has been built over a long period of time, and those relationships as well that are so important for those long-term changes, and how women in STEM and encouraging women in STEM, but also country-led work and the development of all the country-led work and how technical support can be brought into that. And then we had our early career researchers talking about their work in progress, and we heard from about Lao and the impact of health catastrophic effects and economic evaluations. Some of the students and early postdocs presented their work, whole genome sequencing to assess PCV effectiveness against AMR, the pneumonia surveillance that's being done in Lao, and also looking at how PCV may affect severity and transmission by potentially reducing the density of pneumococci. And also then immunology data, B cell data, and whether B cells are a potential marker of pneumococcal disease control. We then had the Health Economics Seminar where we had our panelists and from Indonesia and Fiji and Mongolia and the Philippines, and with myself and Professor Jodie McFernan and Mark Jitt. And so Natalie took us through about some of the broader aspects, not just PCV, but how countries are using vaccine economics to help their decision making, and some of their priorities for decision making and how they make their decisions. We then had, the next day was yesterday, and so we talked about really the more policy sort of side of things with PCV. So we're narrowing down more, for the CRE things, and we had an overview about how our government, the Australian government, provides support to our region, and the coming from COVID, but also now to immunisation more general. And there was the 3 Ps, policy, partnerships, and if anyone can remember the 3rd P, it escapes me, but anyway, but there was a lot of, and then also looking at long-term relationships as well. And so really important to hearing about DFAT's thinking now, and universal healthcare was a key thing as well. And then Dr. Hardeep from WHO in the regional office talked about, from WHO's perspective, the immunisation global plan, and then WIPRO's priorities for the region, and all the other different vaccines that are priorities too, and supporting surveillance as well in the region, and all those other things that go with immunisation importantly as well, such as uptake and safety as well. Then we talked about, really the overview of how many doses really in the schedule. So how many doses do you really need? Is a single dose okay, or in the first year of life, and the need for the timing of the second dose? And we heard a summary of a lot of that data and the evidence behind all of that, and the thinking behind all of that, and also from Kim and also Lei in terms of the work in Vietnam using a catch-up followed by a 1+1 and achieving pneumonia control. And then we had our panelists from countries again hearing. Oh no, sorry. First we had Natalie talking about the profound effect that COVID has had on immunisation budgets, and although immunisation budgets have increased over time, we still don't know a lot about those, about budgets and how countries do their budgeting and things from an outsider's point of view, I guess. And then Mark talked us through about what is the best buys for your dollar, really. Like if you've got limited finances, then how do you prioritise? And then talking about through the health economic side of that, through QALYs and DALYs, and what's the best buy for your health dollar, and with immunisation being a really important aspect of that, but with the new vaccines being more expensive, then the importance of health economics and understanding cost effectiveness. And throughout all of this, the price of vaccines were really raised in terms of really a large barrier, and the large barrier in the inequity of vaccine access, not just that's been really highlighted in COVID, but really it's been ongoing and profound for a long time, and particularly with PCV and many countries having not introduced vaccines still 22 years after the vaccine's been in use in high-income countries. So our panelists then from Thailand and Philippines, from Mongolia, Indonesia and Fiji, as well as from UNICEF and WHO, then put us in the context of where each country was up to with their thinking, and what data needs they may be, where they were with their PCV programs, and what data needs they were thinking about in terms of how to then think about the best use of their money, I guess, and freeing up their program potentially, but also their surveillance needs as well. We then in the afternoon had an immunology session, and we heard from about the methodological issues with correlates of protection, and about loss to follow-up, and how these different things may affect the results, and the importance really of biostatisticians and everything that we do. By and large, we rely on them heavily. And immunology was with Tuan and Paul about really the schedules and the number of doses, and really the future work, and how some of the indications that a single dose with the 10-valent vaccine may be superior to the other vaccines, but after a second dose, PCV13 may be superior. But then looking at what the clinical side and meaning and relevance of that is, and whether the role of B cells being perhaps a better marker potentially of disease control. And then we had some side sessions. Catherine's group gave a microbiology tour, and then we had some CRE project specific meetings with talking. Well, we talked a lot about a lot of things, I guess, but we tried to talk about health economics with our Indonesian colleagues, and also with Anna as well from the Philippines. So, now we're into our last day, and I will now hand over. So really exciting. Just a reminder, we're going to take a photo at some stage of everyone, and so Darren will sort us out at some stage, I think, when that's going to happen. And I'll now hand over to our two chairs for the high-tech surveillance session, which is Associate Professor Catherine Satsky and Anjana Deo. Thank you very much.
Thanks very much, Fiona. So it's my absolute pleasure to welcome everyone to the microbiology session together with my co-chair, Ms. Anjana Deo from Fiji. For those who haven't had a chance to meet yet, I'm Catherine Satsky, head the Translational Microbiology Group at MCRI and the microbiology for our CRE. And it's my real privilege to be working with those in the audience to think about how we can use microbiology to improve public health outcomes. So before I introduce the session and our speakers, just a couple of housekeeping. So today's actually Remembrance Day to mark when the Armistice was signed, kind of reflecting the end of the First World War. So what happens at 11 a.m., which is the 11th hour of the 11th day of the 11th month, is that we have a minute silence. So that should happen during our morning tea, and there's usually an announcement over the speaker. Yeah, if we run a bit over time, it might happen during the session, but everyone will keep to time, I'm sure. So yeah, just a reminder to the speakers, it'd be really fabulous if you keep to time. We have a very packed schedule. And to those in the audience, to hold your questions, because we'll have the Q&A session at the end, like the other sessions. So I guess when we were putting together this session, we had a lot of thoughts and discussions, and hopefully we can draw out some of these in the Q&A. So we're thinking, what are the questions that we need to answer? What sort of surveillance systems are required? So what's the importance of invasive pneumococcal disease surveillance, pneumonia surveillance, carriage in pneumonia, carriage in healthy people? What needs to kind of be part of that and wrapped around it? So we heard from Dr. Sanju from WHO yesterday about the importance of linking epidemiological and laboratory analysis as part of that thinking. And we heard from Dr. Sanjuti Saha, a really nice presentation as well, how we can use tools like genomics or serotyping approaches really as a frame for kind of thinking about public health impact and also collaborative and equitable partnerships. So that leads very nicely into our first speaker, Professor Stephen Bentley, who's a principal staff scientist and team leader at the Wellcome Sanger Institute in the UK. So I'm going to go, I've got a very nice bio here, but I'm going to go off script and I really want to share with you why we invited Stephen to present today. And because of the fantastic alignment with the CRE. So Stephen, embodies research excellence. He's an absolute giant in the field of pneumococcal genomics. The global pneumococcal sequencing project has sequenced over 25,000 pneumococcal genomes. But that's not all. And I think really important for us in the CRE is his commitment to public health impact and thinking about how genomics can inform those decisions, and equitable and long-term partnerships with collaborators. So I'm sure you agree this aligns very well with the CRE, and we're very pleased to have Stephen as part of our CRE, but also the goals of each and everyone in the room today. So I'll hand over to Stephen, who's going to present to us, and thank him for dialing in live from the UK despite the time difference, and welcome you here today, Stephen. Thank you.
Thank you very much, Catherine. I'm going to hope that you can all hear me. So first, I'd just like to express my sort of apologies and regrets for not being there in person. I did plan to come over, but unfortunately had to cancel my trip, and I promised to do my best to come over next year sometime and meet you all in person. So this isn't going to be a very scientific talk. It's going to be really about the practicalities of what we did in terms of putting together the global pneumococcal sequencing project. Mostly challenges and some successes that we've had over that time period. So I'll begin by just giving you an outline of the project itself and how we ran the project, and then I'll go into some lessons that we learned along the way, and then finish with some thoughts on how things might work out in the future. So this is a bit of an obvious slide to the audience we have today. So it is an important pathogen. And in one of the, I think from a genomic surveillance point of view, I think the fact that it's an endemic pathogen is really useful in this post-COVID world where there's lots of excitement about genomic surveillance. I think endemic pathogens are going to be the way that we build systems that are going to be robust for pandemic preparedness. So I think that's an important point. But for the pneumococcus, as you all know, we have very effective vaccines, but those vaccines don't cover the whole species. So we knew right from the beginning that the population would have the ability to evade those vaccines, and we didn't really know from the beginning actually how that would work. So from my point of view, my initial interest was the academic interest in what the mechanisms of evolution were going to be, and to see if we could try and understand that. And then from the public health point of view, there's an interest in knowing or being able to predict potentially how the patterns of vaccine evasion were going to work, so you could try and anticipate that. So the project itself was conceived in 2009, and that was around the time when next generation sequencing was just coming online and we were learning how to adapt it to work with small genomes. So with most sequencing, it's always the technology is developed for sequencing human genomes, but around 2009 we were learning how to multiplex our samples, and that opened the door to population genomics for microorganisms. And then with the backing of the Gates Foundation, we managed to initiate that project in 2011. So looking back over the time, it's really fallen into two phases, the way the project has run so far. And so if we just look at phase one, I mean, this aligns with the funding that we had, but initially it really was a proof of concept. So nobody had suggested at that point that we could do a global surveillance of any pathogen. Because as I said, you know, the technology was just coming on stream. So it was really a proof of concept. Another important factor was the fact that to do it properly globally, we were going to have to build a global partnership, and I'll say a little bit more about that. And then another really important point is that the sequencing was all centralized at Sanger in that first phase. So that was DNA or strains being shipped to Sanger, and all of the sequencing happening at Sanger. And that's obviously not the way that things should be done now, but that's the way it made sense to set the project up in the first place. It was really about where the technology was available and economy of scale that we had at Sanger as well. So the project grew from, we had initially 3 partners in Africa, so in Gambia, Malawi, and South Africa. And that grew, and I'll talk a little bit more about that. That grew to over 50 partners in over 50 countries. So, and in the end, we sequenced over 31,000 genomes, which represented 59 countries, which was very satisfying. That we actually, in that partner development, we prioritized countries that were eligible for Gavi support for vaccine rollout. Through that process, through that building that partnership, we managed to engage with 137 different scientists. And I mean, when I say engaged, these were people who were engaged in data analysis and writing of papers. So really involving everybody from across the partnership. And that's reflected in a large number of sub-studies that we created as collaborators outside of the initial aims of the project. And then that's also reflected in publications with our local partners representing first and last authorships. But so in terms of the proof of concept, these last 2 points here, we did prove the concept that we would be able to identify global high-risk clones in the post-vaccine era. And really, what was really satisfying is that information has then been taken on to inform the formulation of third generation vaccines. So I think a big tick in terms of the proof of concept. So that helped to persuade the Gates Foundation to renew the funding, and so we started the next phase, and that was, so we summarize that phase simply in these two different points. So one is decentralization of the sequencing, which involves lots of local capacity building, and I'll talk about that in a moment. But then another point was filling data gaps. So this was really emphasized by this paper in 2018 by Weil et al., which many of you will be familiar with. But the thing that struck us was that showed that 50% of the mortality was in just 4 countries. And when we looked in our data set from the first phase, those countries were represented by less than 6% of the data. So that was a big gap that we needed to fill, and we are engaging very strongly with those countries to try and fill those data gaps. Okay, so that's how how the project has run so far. And so the next few slides, I'll just reflect on some of the things that we've learned along the way. So one thing that was really important was that building of the partnership. And the way we went about doing that was initially it was just identifying our established collaborators, so people that we already knew, we already worked with, we knew would have samples that were relevant. Then the next phase was to link, reach out to partners of partners and go through that process. But what was really interesting and important was advertising the project at the international conferences. So ISPPD was a real big one, where once people got to know about the project, then we could actually meet people and build that partnership there. And then the final part, which was actually surprisingly productive, was simply looking through the literature and just keeping an eye on the literature for people who were collecting relevant samples in countries where we didn't have any representation, and then reaching out to those to try and help us fill the geographical data gaps. So through that process, we learned about the variability in partners. So people, groups were coming from very different perspectives, very different backgrounds. Their local capabilities were different, their local interests were different, and their local priorities were different. So in each case, we had very careful discussions and ended up, I would say, creating a bespoke partnership in each case. We never had a template for how the collaboration and the partnership would work. And through those conversations, we would carefully explain the central aims of the project, but then that's where those sub-studies came out, because people would then start to talk about their own interests, and we'd sort of discuss the science around that. And it was really, really fruitful. So we had to be open and flexible. As I say, everything became quite bespoke in terms of our one-to-one relationships. And about 2 years into phase 1, we realized that we were going to have to write all of this down. And that's how we created what we termed our collaboration and publication guidelines document. And that was simply, so an important point is that was not a legal document. We were not asking anybody to sign anything. But it was really to reassure partners that there was going to be fair play and fair benefit sharing for the whole project, and that was, I think, really, really quite important, and was actually pretty effective as well. So I mentioned legal documents. The next lesson learned was about legal documents. So remember, the project started in 2011, and at that time, from Sanger, we never asked anybody for an MTA. And actually, in most cases at that time, partners never asked for an MTA either. But that's changed quite dramatically over the years. And so now, there I'm listing different acronyms for pieces of paperwork that many of you will be familiar with. And some of you may be familiar with the Nagoya Protocol, which has really had a massive impact in recent years. So all this combined is a lot of paperwork, but it's also each one of those pieces of paperwork potentially grinds things to a halt. So we've got to take them very, very seriously. And at the bottom here, I'm just giving you an idea of the number of pieces of paperwork that we've had to deal with so far. So that's a lot, and I completely admit that initially we completely underestimated the burden that was going to create for us. But we've learned, and one of the things that we've learned is that we need, if you're going to set up a partnership in that way, then you need a decent central legal capacity. So at Sanger, that's had to grow because we were putting a lot of demand on that group. So the legal department has grown. I'm pretty happy that we've learned how to deal with the volume of paperwork that's necessary. But the other thing that we've learned is that local capacity for such legal paperwork can also vary enormously, which means that we've got to be again, we've got to be flexible in those communications and in our expectations. And I would say that going forwards, it's important that we bear that sort of thing in mind and factor it into budgets when we're applying for funding, because it is so crucial. We've tried to keep things simple and flexible, and always tried to be as patient as possible. And I think an important message here is that the delays that you see in the back and forth of these kinds of pieces of paperwork are rarely due to lack of enthusiasm from the person, the scientist, or the epidemiologist that you're working with. So we should always bear that in mind. So it's not a lack of enthusiasm; it's other just bureaucratic problems. And one of my recommendations is to keep scientists out as much as possible and try and, as soon as possible, get lawyers to speak to lawyers, because I think asking a scientist often to read a legal piece of paperwork will slow you down. Okay, so we got over that, and then so now let's move on to actual developing local sequencing capacity and capacity for analysis. So this is really about phase 2, or preparation for phase 2 of the project. We conducted a survey of all of our partners, who were quite a number by then, quite a detailed survey to try and assess people's current capacity for sequencing and analysis, and then also gauge their aspirations. So not everybody wants to develop a full-on sequencing lab and spend a lot of time doing analysis. So understanding the aspirations is also really important. And then from the feedback that we got from that survey, that then helped us to design resources for training and for capacity building. And that ranged, and you'll see out there now, it's fantastic to see the variety of learning materials that there are out there. So that, for us, it ranged simply from a video that you could go and watch online and just maybe learn something about a little bit of one specific bioinformatics technique, all the way through local training courses, including train the trainer aspects, so that the local trainees can then go on to teach others, and lab exchanges, so exchanges between different groups, have become quite common. And it's not just people coming to Sanger or Sanger people going out to partners, it's partners exchanging with each other through the sort of network that we've created. And then finally, we found it really important to have support networks behind all of this. So just online groups, so we use Slack quite a lot. We have instant messaging. So on the back of training, if people have any questions, just to help them sort of practice the art afterwards, there's always someone on hand who can give a quick response to simple questions, almost like sharing an office with somebody. And then we also have a seminar series, which has been really good for getting people together once a month, though that's challenging across different time zones, as you guys will fully appreciate. And then my final point on this slide is that we put a lot of effort into developing our training materials, but there are lots of organizations out there now doing the same kind of thing, and so we should all try and bear that in mind and avoid duplication of efforts. And that, in my experience, organizations like H3A Bionet, Phage, and Wellcome Connecting Sciences are excellent in generating and delivering that kind of training, and they're also very generous in terms of their time and being willing to share. So I'm pretty optimistic that in the next few years, one of those organizations, and I'm nagging all three of them, will create some kind of web resource where if you wanted to create some a training for whoever in genomic data analysis, you can almost go in and pick things off a shelf and customize a workshop for yourself, or with lots of free material. So that's lessons learned. I just want to now talk to you about our academic research. So the GPS project has been important to us for the last 10 years, but at the same time, we're also at Sanger doing lots of basic research, discovery science. So here, I've just listed a few things that we've been doing that are relevant to pneumo, and I think relevant to pneumo surveillance as well. So we have Jerry Tonkin-Hill has just finished his PhD, and he was doing some really great work looking at within host evolution and transmission using deep sequencing of pneumo from swabs. I have a student at the moment, Sophie Bellman, who's using mathematical modeling approaches to try and use the genomic data to understand and quantify how pneumos actually spread geographically. We're doing another student is looking at essentially GWAS, statistical genetics, to really fine-tune our view of out beyond capsule what is important in what are the genetic markers of virulence. And then there's well-established methods for in population dynamics, looking at how populations respond to interventions. So all of those areas of research, I think, are important and relevant to our thinking about how to do surveillance going forwards. And that's leading me more and more towards thinking about the importance of carriage surveillance. So using swabbing of healthy individuals, hopefully longitudinally. It's always good if you can do it longitudinally, because then you can monitor change over time. And these days you hear a lot of people talking about environmental surveillance. So often in terms of wastewater sampling. That's not going to be appropriate for pneumo, but I like to think of this more as ecological surveillance, where you're going to the healthy individual into the nasopharynx, which is where that bacteria actually evolves. You're going into its ecological niche. So Jerry's project was important because it showed us how deep sequencing can detect minor variants in carriage. And that's obviously important because one of the things that we always worry about missing in carriage is those important virulent strains that are rarely found in carriage. So serotype 1 being the classic case. And so what Jerry showed in his work is that actually serotype 1, for example, is almost, when it is detected, it's almost always there as a minority variant in multiple carriage, and actually at quite low percentages. But he's shown that with the deep sequencing technology, we can actually detect all the way down to about 1% minority variant. So that gives us the confidence that we can actually capture those virulent strains that are rarely seen in carriage. So from the genome data, we have pretty well established algorithms for identifying what strains are present in the sample, what their serotype is, what their AMR profile is. And then also from the GWAS work we're doing, you can get a measure of invasiveness of each individual strain. The next step we're now working on is to then take that carriage population and apply models to infer what the disease population will look like based on that carriage population. And as I said, there's methods for being able to forecast how a population will respond to an intervention. So if we have new formulations of vaccines, we can apply those models to predict how that population will look after the vaccine. And then with the work that we're doing on strain migration, we can also start to think about how one country might influence. You could be influenced by strains migrating from a neighbouring country. So putting that package all together, I think is my point here is to just say that there's a lot of thought now and a lot of data that can help us to really fine-tune the way we do genomic surveillance. Okay, so this is actually my final slide, and it's just a very general point about genomic surveillance. So it's not really specifically about pneumo. And actually, this was a slide that I presented to the Grand Challenges meeting a couple of weeks ago, where there was a lot of discussion about genomic surveillance. And I was actually quite concerned that a lot of that discussion was going on at a very high level. So COVID has clearly quickened the pace, and it's attracted a lot of attention to genomic surveillance, and rightly so. Genome data has been really important in a lot of management of the pandemic in different countries. But we really need to maintain that momentum. And as I said earlier, I think endemic disease is going to be the way to go if you want to build pandemic preparedness into the future. But there are many competing priorities when you consider the whole system from the sample collected either from carriage or disease or environment or wastewater or whatever. So you've got to go all the way from the sample and all the way through to policy. So when you put all of the pieces together, it becomes a very complex discussion. And I in my mind, so I've been party to many of those conversations and been a little bit overwhelmed by many of the details. And so in my mind, I've tried to simplify it and boil it down to the words that I have here. So there's a lot of interest in pathogen agnostic things. So people wanting to solve many things by creating a solution that's agnostic to the pathogen. And that's a sensible approach. But on the other side, there's also a need for a focus on many things that will actually still be specific to different pathogens in terms of just handling collecting samples, processing samples, and analyzing the data itself as well. There's going to be many specific nuances to that data analysis. So in a way, I feel that becomes a global versus local issue, where central organizations like WHO may be going for these pathogen agnostic things, and potentially there's a competing draw on funds from the local priorities. And then broadly speaking, this is for many complex systems, you'll have a top-down versus bottom-up sort of competition. And then my final point here is just to really, I've found the word enthusiasm really useful thing to focus on. So here I'm saying reason. This is the activity of trying to theorize that perfect system at the top level, at the risk of neglecting the enthusiasm at the grassroots. The people who are actually going to generate the real data. And so my recommendation to the funders was to say, let's make sure that we nurture those local communities, so be they pathogen specific or physically local communities, to maintain that enthusiasm. And I think those are the places where you're going to get practical solutions created. while at the same time we still do need to create that overarching infrastructure, but we should allow those local communities to converge naturally within that system rather than imposing the system on them. So this is literally my final slide, and I think I've got a couple of minutes left. I just want to acknowledge from the GPS point of view, the groups that have made this all possible. So to begin with, the Wellcome Trust, for the fact that they've had a long-term investment in infectious diseases. And then the Wellcome Trust obviously created the Sanger Institute, where for the past 25 years, there's been genome analysis of pathogens, going all the way back to the first TB genome. And that really gave us a nice foundation in 2009 to give us the confidence to say, okay, let's give this a go. I'd also like to acknowledge the Gates Foundation, not just for their money, but for the really clear conversations that we've had over the years about how to deliver, what the priorities are. And Keith and Leslie have also been crucial to that. It's been clearly an advantage that Keith was initially outside at Emory and then moved inside to the Gates Foundation. So that's been a very useful move for us. And then I wanted to really acknowledge the bioinformatics community globally. It's such a generous community of people in terms of sharing ideas, sharing code is really important. And I think that's made a massive contribution to the GPS project, but also had a huge impact with COVID as well. And then finally, I should acknowledge our local partners, who, and my slides have just disappeared. Yeah, so our local partners who, without their involvement, the project would not have been a success. So I'll stop there. Thank you very much.
Well, thank you very much, Stephen. That was a fantastic presentation, and I think really did an amazing job of picking up some of the things that we've been discussing over the last couple of days, but giving us a lot of food for thought, extending those, and also bringing in some new elements. So I know I asked people to hold their questions, but we have a couple of minutes, and I guess mindful of the time difference, it might be good. I'm not sure if Stephen can stay up for the whole session and the Q&A. So I'd like to open the floor now. If anyone has any questions for Stephen, we can do that now. Yep, Fiona.
Oh, thanks very much, Stephen. It's Fiona Russell here. Great to hear about all your work and the evolution of it all over time, and the process of how you got there. My question is in relation to, I think your last few slides was about how COVID has sort of changed and brought attention to things, and whether, you know, and you mentioned there about surveillance systems, agnostic versus obviously there's pathogen-specific things that are needed and so forth. And yesterday we heard from WHO and from their regional office, Dr. Hardeep, talking about surveillance systems and trying to harmonise them, I guess, so as much as possible, you know, rather than some of these siloed systems, but also how to bring things together more if possible, I suppose, thinking from a programmatic point of view from ministry. So I'm just sort of wondering, in the conversations that you're having at that higher level with WHO, because obviously there's the importance, as you've mentioned, there's specific ways of doing this for pneumococcus and other ways for, an environmental surveillance isn't a thing for pneumococci, but yeah, my question is really related to, who's at the table in these discussions, because, what we've seen with COVID is that, people with maybe new to COVID don't realise the history of a whole lot of other things that have been developed sort of over time, and how you could potentially be opportunistic as well where things have already been developed or thought about over a long period of time, and how you can add on to these things and augment things that are already existing rather than starting from scratch. So I just want to know whether, you've got the standard communicable disease people who do surveillance also at the same table as the genomics people, and, coming together to try and harmonise these things, because from a country, it is quite difficult, and you end up having a whole range of things and people with their pet things sort of, so I'd be very interested to hear about that.
So I'm going to boil your question down to the who's at the table point, and I think the WHO is clearly going to play an important role in the development of genomic surveillance, just because of their, if nothing else, through their convening power to actually get people to come to the table. There are lots of consultants around, I would say, who are being tasked with the challenge of making sense of it all and advising on the best way forwards. So that really does concern me a little bit, and that's really what that last slide was all about. I can see a risk of talking shops being created that really limit progress. So I think another way of answering is that who's not at the table, I think, is a lot of the time national representatives who have experience and knowledge about their own countries, and that's really a concern. The other, I don't want to sound too pessimistic, but the other thing that you see in these high-level meetings is the pathogens that are considered. So it's the usual suspects where it basically says malaria, TB, HIV, and then people think, oh no, the list's getting too long. Let's not make long lists. So there is, again, the danger that there will be too much focus on too few pathogens, and then other things can be potentially neglected. So one thing that I and others have suggested is that to actually focus minds a little bit, one thing that could be done is to actually create targets in terms of how many genomes do we want for each of these pathogens? And then if you take it pathogen one at a time, and you will obviously have to create a ranked list of your priority pathogens. But if we took now the top, say, 25 pathogens in the world, you would very quickly reach a point where you've got hardly any genomes. And I think if you say, okay, that's an important pathogen, we have no data for it, let's fund an organization, let's fund something to actually change that. And you can start really quickly. And I think if you could, I mean, I'm kind of recommending that you follow the same path as we did with pneumo, where you start from scratch and you build a big database, you build a partnership. And if you have those partnerships for each of those pathogens, there is the risk of you having what some people might think of as inefficiencies, because you're going to be doing the same thing again and again in the same place because they're interested in that same pathogen. But I don't worry about that. I think the advantage that you have is that actually builds one on top of the other, and also that somewhat addresses the point that in different countries they will have different priority pathogens. So if your priority pathogens are low down on the list, then you're gonna struggle to get the resources and the support that you actually need. Sorry, that was a long answer to a long question.
Yeah, that's all right. I think maybe Kim.
Yeah, thanks, Stephen. It's Kim Holland. There's an exercise going on at the moment from WHO where they've as part of the IA 2030 exercise, they are identifying the next round of pathogens. I think they're looking at about 10, and they're going region to region, undertaking a sort of an extensive consultation to try to understand what are the most important pathogens, with the view to supporting vaccine development where it's not existing, or where it's appropriate to push it forward. So that exercise is happening, and I think it's probably going to become more evident over the coming months. So I'm not sure, with all these things, it's a problem as a kind of, it becomes a bit like a popularity contest or something, where people are putting forward their favorite pathogen. But I think that there is an effort being made to try and look at this in an equanimous way, to try and understand what are the really important public health pathogens, and the ones for which the effort to improve the development of vaccines, at least, is justified. And so the monitoring, genomic monitoring that you're speaking about, fits very closely with that, and should really be coordinated with it, I think. So
yeah,
we can talk more about that.
Yeah, no, that sounds great. So I wasn't aware of that WHO initiative, but as you were saying, yeah, I was, if it's focuses on vaccine development, obviously, as you say, genomic surveillance around all of that is, in most cases, will be beneficial.
Fantastic. So I think in the interest of time, we might leave it there, but really appreciate you joining us, Stephen, and we look forward to welcome you in person, hopefully in the next year or so. So please join with me to thank Stephen. So we'll now move on to our next speaker, Professor William Pommet, who's a fantastic researcher, particularly around respiratory diseases, to understand vaccine immunology, including pneumonia as a focus. He really has the overall goal of helping his country, Papua New Guinea, introduce PCV into the national schedule, and is director of the Papua New Guinea Institute of Medical Research. And we heard from Stephanie Williams from DFAT about what a really integral role the PNG-IMR plays in that country, in promoting and ensuring the health of everyone in Papua New Guinea. So unfortunately, sometimes the internet from Papua New Guinea isn't the best. So Willie's taken the precaution of filming his talk in advance. So we'll share that. But I believe that he's online on the Q&A, so he can pop some answers in the chat and hopefully also respond when we get to our Q&A session.
Good morning, everyone. Thank you for giving me the opportunity to present at this important symposium. I'm grateful to present, at least online, on the sustainable surveillance system for infectious disease in PNG. We know that surveillance of infectious disease is integral to health and security of any country, and establishing a system that can work as an early warning system to inform relevant authorities on clusters of cases for intervention to take place are essential. Before I continue, I want to pay tribute to this young lady on behalf of my colleagues and I from Papua New Guinea, a young, vibrant, caring, and generous person committed to pneumonia research to improve outcomes for high-risk population like ours. She was on a path to greatness, and we are deeply saddened by her passing. May she rest in peace. For those of you who may not know where PNG is, this world map gives you a GPS location of where we are situated. We are located to the north of Australia and share the eastern half of the island of New Guinea with Indonesia, the western half being West Papua. PNG, like many low and middle income countries, has a high burden of infectious disease and a growing burden of non-communicable diseases. Diseases like pneumonia, malaria, diarrhea, TB, HIV, and STIs are among the highest reasons for deaths and hospitalization. Outbreaks such as measles in 2015, polio in 2018, and COVID-19 in 2020, and now malaria and karimu in the highlands compound and stretch the limited resources available. With pandemic like the COVID-19 and the response required, this disrupts other essential services like maternal and child health, immunization programs, and so on. This slide gives you an idea of the changing epidemiology of deaths, main causes of deaths in PNG. The country has surveillance system in place which provide annual reports for resource allocation and intervention to health facilities. The main one is the National Health Information System, which is a paper-based system and includes a number of indicators for reporting to the National Department of Health. Established more than 20 years ago, this system has been working well, but improvements obviously are needed. Recently, the electronic version, or the ENHIS, was introduced. This system is tablet-based and has 29 indicators. Indicator 1 being pneumonia case fatality rates in children under 5 in health facilities, highlighting the importance of pneumonia as a public health problem in PNG. The other disease programs have their own specific reporting systems, such as TB, HIV, malaria, and immunization. The 2020 Sector Performance Annual Review booklet is an example of the main outcomes of the ENHIS and NHIS reporting system. Aside from this system, the Field Epidemiology Training Program, a partnership between the National Department of Health and the University of Newcastle, has personnel operating out of each province or each district in each province that report outbreak, potential disease, and response, as well as provide information on operational research. The new National Health Plan 2020 to 2030 includes the establishment of the Public Health Institute and the National Reference Lab, which will help to provide support for the surveillance system into the future. The Institute of Medical Research also complements the National Department of Health by helping to establish a number of surveillance programs. In particular, the Institute is the WHO National Influenza Center that conducts influenza surveillance, including outbreak diseases. Also, we conduct surveillance on rotavirus, vaccine-preventable diseases, malaria, and also the chest programs which is sentinel site surveillance across each of the region in Papua New Guinea. PNG as a country has gained from the pandemic. In 2020, only the PNG IMR and Central Public Health Laboratory had the capacity for PCR technology. As the pandemic progressed, and by 2021, 60 public and 19 private laboratories have been established and can conduct PCR and gene express diagnosis for COVID-19 and can potentially be used for other diseases. PNG IMR has also gained by having a state-of-the-art PCR equipment brought to the Institute, thanks primarily to DFAT and WHO. In the last few months, the IMR has benefited by introducing COVID-19 variant of concern PCR to help the country, multiple serology technology for serology or exposure to COVID-19 and other pathogens, and the establishment of the mean iron nanopore whole genome sequencing. This is now established for the country. The main concern now is to maintain, build analytical capacity, and utilize the technology to test other pathogens, be it flu, human coronavirus, RSV, and or bacterial pathogen. A multiplex PCR is also being optimized to test for pathogens should a COVID-19 test given a negative result in symptomatic patients. Given the establishment of surveillance systems plus laboratory capacity, it is now an ideal time to establish a severe acute respiratory disease surveillance for high-risk hospitals in Papua New Guinea. Using WHO case definition and criteria, this system would benefit greatly to reporting heightened SARI activities, therefore serve as early warning system. Trained FETP fellows in provinces would provide complementary surveillance by reporting from health facilities. So what are the main challenges? Human resource being the primary challenge, as many staff who were repurposed to COVID-19 have now got to go back to their original job descriptions. Coordination of activities between entities must also be better, given the experience now with COVID. Supply and demand for commodities and laboratory reagents, for example, can be an issue for developing countries. Non-health infrastructure such as water supply, power supply, internet, roads, nature, violent confrontation, all also are the main challenges for countries like Papua New Guinea and for surveillance systems. Database analysis are also a challenge, and we need human resources to conduct analysis of that data that's being generated. Risk communication and community engagement need to be much better, as has been shown by COVID-19, where vaccine hesitancy is a big problem for Papua New Guinea. And through all of this, funding, especially from the main government of Papua New Guinea, needs to be allocated for surveillance system to work well. So as a way forward for PNG, surveillance and laboratory capacity have been established. This needs to be strengthened, maintained, and probably a better system as well established. Laboratory system must have standard operating procedures for multiple pathogen testing, and clinicians must be aware of the etiology and clinical presentations of diseases at hospitals, and this requires continuous research. Training and capacity building must be maintained and continued and strengthened. The new Public Health Institute and the National Reference Lab, documented in the National Health Plan 2021 to 2030, could be taking much of the responsibilities mentioned in this presentation. The Institute of Medical Research will, of course, be aiding the surveillance and laboratory systems by continuing to conduct implementation research to help make sure that the system is seamless. Finally, thank you everyone for your attention. I welcome any questions.
I really like how your talk captured both the long history and contribution of PNG IMR, but also all the recent changes that have happened with COVID, which I think everyone in the audience can relate to. And I'd also really like to thank you for your very kind words about our friend and colleague, Dr. Yana Lai. I'm sure many in the room had the privilege of working with Yana, who made an amazing contribution to public health in her short life. And we share Dr. Pomat's sorrow in her passing. So thank you for that. So we'll come back to some questions for Willie at the end, but for now I'd like to introduce my co-chair, Ms. Anjana Dio from Fiji, who will chair the rest of the session.
Thank you, Catherine. Before I introduce the next speaker, I'm Anjana Deo from Fiji Ministry of Health as a senior research officer, and I'm also a secretariat to Fiji Human Health Research Ethics Committee, and I also hold masters in public health. Calling on to the next presenter is Dr. Jonathan Jacobson and Dr. Elisa Nicolau. I hope I have pronounced the names well. To introduce, they are microbiologists from the Translations Microbiology Group at MCRI. Their current research focuses on establishing molecular methods as access thoracic empyema through the MATE and MATE Asia studies, which they are presenting today. Welcoming Dr. Jonathan.
So it's a great pleasure to be able to present today with my friend and colleague, Dr. Elisa Nicolau, on behalf of the Translational Microbiology Group here at MCRI. And I'd like to extend a very heartfelt g'day, mate, to our growing international empyema research community. So this presentation will be broken down into 3 different projects, but these are very much interconnected and will flow quite well together, I feel. So the first aspect of this project, we'll be looking at the molecular assessment of thoracic empyema, or the MATE project, which is being conducted here in Melbourne. The aim of this project is to improve bacterial identification for empyema. I'll then discuss our recent data that we've obtained looking at the serotype replacement in empyema here in Australia. And then I'll hand over to Eliza, who will be outlining the exciting future for the MAID project as it gets rolled out across the Asia Pacific region. Empyema is a common complication of community-acquired pneumonia, which occurs in around 5% of children that develop a community-acquired pneumonia. Empyema is diagnosed by fluid which contains pus collecting in the pleural space around the lungs. And treatment typically involves surgical drainage of this pleural fluid and initially untargeted antibiotic therapy. Now, this is chosen empirically to begin with, and in an attempt to address the most likely bacterial causes. So it's often broad spectrum. This can also have unwanted side effects for the patient and increases the risk of the potential of antibiotic resistance arising. So in an ideal situation, obtaining the identity of the bacteria causing the disease in each case will allow treating clinicians to transition to targeted or specific antibiotic therapy. But unfortunately, the most common or gold standard practice to obtain the bacterial identity is bacterial culture. And for this particular condition, bacterial culture has a fairly low sensitivity rate, that being less than 20% in our experience. So we began the MAID project to improve bacterial identification for empyema. So in this observational study located here in Melbourne, Australia, which began in March of 2019, we're recruiting 150 participants who are children under the age of 18 who are hospitalized with community-acquired pneumonia that develops into empyema and who have pleural fluid drained. And we've developed a molecular test, which is a qPCR-based test to improve diagnostics for this condition. So our new molecular test is a multiplex qPCR platform, which is able to detect the 4 most common bacterial species that cause empyema in children. So this is the Streptococcus pneumoniae, Streptococcus pyogenes, Staphylococcus aureus, and Haemophilus influenzae. And when we compare the clinical sensitivity between the current gold standard, which is bacterial culture, to our new molecular test, we can see that using bacterial culture, again, in the setting of the Royal Children's Hospital, a bacterial identity was obtained in 18% of empyema cases that were tested. In contrast, using our molecular test at the MCRI laboratories, we obtained the bacterial identity in 85%, which is around a 5-fold increase in detection. Here, looking at the bacterial etiology of empyema in Australia, you can see that the pneumococcus is by far the predominant cause, responsible for about 72% of cases. Our clinical team performed a preliminary assessment of the potential clinical impact that this diagnostic test would have if it had been available in these cases. And they found that if this multiplex PCR had been available, it may have reduced the duration of untargeted antibiotics in 70% of cases by a median of 20 days. So moving forward, I'll now give an overview of the serotype data that we've obtained from these pneumococcal positive empyema cases in Melbourne. We can assess the early impact of the PCV schedule change that occurred in Australia. So a little bit of background about the PCV13 deployment in Australia. So PCV13 became the vaccine of choice in July of 2011 in Australia, and this was administered in a 3+0 schedule, so 3 primary doses with no booster. And in July of 2018, Australia joined a very small number of countries to transition to schedule to a 2+1 schedule. And this was introduced to address the increase in breakthrough cases and to provide better protection in the second year of life. The MAID study began in March of 2019 and is ongoing. So we can use our results that we've obtained within this 2+1 era and compare to studies that were performed earlier in the 3+0 era to see what effect that schedule change may have had. So to do this, as I mentioned before, we have very low culture positivity rates for our empyemas, which means we had to resort to a molecular assay to determine the serotype in each case. So we're using the pneumococcal TACMan array card platform, so basically, which is called PneumoTac. So basically, this is a sequential qPCR platform which is capable of detecting 94 pneumococcal serotypes simultaneously. We performed a small pilot study where we generated 123 lab-prepared samples, which we spiked, their pleural fluid samples, which we spiked with 29 different serotypes covering the 13 vaccine types and 16 non-vaccine types. And then we tested our Pneumotac assay. We found that Pneumotac had a clinical sensitivity of 97% and a specificity of 100%, which was very encouraging. We then applied the Pneumotac assay to our clinical samples that we'd obtained. And you can see the serotype epidemiology in this pie chart here, and you can see the striking predominance of serotype 3 in pneumococcal empyema in Australia. This is still very early data, but we're comparing here on the right-hand side of this table from the March 2019 to present. So that's our 2+1 era, that's the MATE study, to a former study that was performed up in Sydney by a different group in the 3+0 era of PCV13. And we can compare the predominance of each serotype. What's very interesting is even in the 3+0 era, serotype 3 was the predominant cause. And there hasn't been very much shift in the percentage of cases that are caused by serotype 3. What is interesting is that in our study, we haven't seen any serotype 19A, though numbers are admittedly quite low. Although we have seen an increase in the incidence of 19F. We haven't seen very much movement in the incidence of non-vaccine types as well. So this study is ongoing. We look forward to providing updated data in future. So I'll now pass on to Elisa to cover the next phase of the project, the MATE Asia study.
Thank you, Jonathan. Hello, everyone. So bringing back to empyema studies, based on the excellent results we got from the MATE empyema in Australia, excellent leading by Jonathan, we believe and we are confident that our molecular diagnostic assay will improve empyema diagnosis in children. So with the MATE Asia study, we seek to bring this molecular test in Asia and where the burden of disease is greatest. So in the few next slides, I would like to give an overview of the MATE Asia study, summarize some progress up to date, and conclude with some future remarks from all our studies in empyema. So the MATE Asia study is a multi-center prospective observational study that will follow the same framework as the MATE in Australia. We aim to recruit children less than 18 years of age who are in patients with suspected bacterial pleural empyema. And in total, we aim for 400 children that will be recruited locally from 9 different hospital sites from 5 different Asian countries, including Thailand, the Philippines, Indonesia, Cambodia, and Hong Kong. And also we have the capacity to include 1 more country in the near future. So the main aim of MATE Asia study is to assess the performance of our molecular diagnostic test in our sites in Asia and gather all the necessary evidence so we can implement our test in their standard diagnostic procedure after the study completion. We anticipate that the pneumonia epidemiology will be different in Asia compared to other settings, so gathering local evidence is necessary. Therefore, we aim for all primary activities of these studies to be performed in country and supervised by our in-country local PIs. But also we aim the pneumococcal positive pleural fluid samples to be serotyped and gather all the necessary evidence and data we need for circulating serotypes in Asia. The pleural fluid invasive serotypes, they reflect broad patterns of other serotypes that in using invasive pneumococcal syndromes. So we are very happy with the MATE Asia that we get the opportunity to use the pleural fluid samples for pneumococcal serotype. So here in this diagram, we have some activities that we will perform in this throughout the MATE Asia study, before the study commencing, during the study initiation, towards the study completion. So far, we had main baseline ethics application done here in MCRI. We have now the ethics ready, and we have all the legal agreements given back in the sites. So now we are in the progress that we initiate the ethics submission locally. Here, the team in MCRI works hard to gather all the necessary information. So we are planning to start our study early next year, January, hopefully end of January 2023. So we are in the process of making the lab manuals, documentation, optimization of experiments. We want the study to run for 3 years. We aim for the in-local recruitment of 27 months. We will do some site initiation visits, so we make sure that everything will run locally in a nice way. And then we will also aim to provide staff training, so to make sure that everything runs smoothly within our sites. The collected samples will arrive, the primary activities will be in country, as I said before, but the remaining samples will be sent to MCRI in the half and at the end of the study. We have a very good communication so far with our sites. We have done 17 meetings through online. And the lab leads are meeting regularly, discussing progress and SOPs and everything to get ready for the study. So we are very happy for all this support. Now, to conclude, our studies will bring the benefits of molecular diagnostic to those that need it the most. So we have 3 main aims with our studies: to improve patient care, to increase pneumococcal serotype data for Asia, and to investigate serotype replacement in Australia. We see a great potential, translational potential of using our diagnostic tool. So our future vision is to use our molecular test to other sites in Asia and beyond Asia. We will do some metagenomic analysis to investigate the overall etiology and pathogenesis of empyema in children. We would like to introduce a second panel of less common or country-specific causes, according to the results that we will get from the analysis of the samples from our sites. And finally, we believe that this molecular assay can be used for other clinical specimens and for syndromes that they are culture negative, like empyema. So on behalf of the team, we would like to thank the META participants and also our internal and external collaborations for their support. And thank you very much from both me and Jonathan.
Thank you, Dr. Jonathan and Dr. Elisa. We'll have the Q&A at the end. Now I'd like to introduce Dr. John Hart. He is a medical epidemiologist from the Asia Pacific Health Group at MCRI. He has a background at tropical medicine and international health with experience conducting clinical trials in sub-Saharan Africa and Asia. His current work focuses on improving child and neonatal health in the Asia Pacific region. I would like to also acknowledge Ms. Eleanor Neal. She's an epidemiologist from the Asia Pacific Health Group at MCRI. She's also contributed to this study. Unfortunately, she is not is able to attend this session today. Welcoming Dr. John Hart.
Thank you very much, Anjana, and good morning, everyone. So I'm going to talk about the P-carriage project, which looks at pneumococcal carriage serotype replacement following PCV introduction, and the role of carriage in determining if pneumococcal disease is controlled. So firstly, we know that infections due to pneumococci are a leading cause of morbidity and mortality, especially in low-income settings. And the introduction of serotype-specific PCV has substantially reduced invasive pneumococcal disease, or IPD. So PCV formulation started with PCV7, targeting 7 pneumococcal serotypes known to cause IPD. And that was followed by PCV10 and PCV13, subsequently PCV15 and PCV20, and higher valency PCVs are in development. So PCVs reduce carriage of vaccine serotype pneumococci among vaccinated children. That's their direct effects. And this also interrupts the transmission of vaccine serotype pneumococci among vaccinated and unvaccinated people, and they're the indirect effects. And it's this combination of direct and indirect effects that leads to the reduction in pneumococcal disease. However, reducing the carriage of vaccine serotypes provides an opportunity for replacement in carriage with non-vaccine serotypes, and that's the phenomenon we call serotype replacement. So generally, non-vaccine serotypes are less pathogenic than vaccine serotypes, but an increase in non-vaccine serotype IPD has been observed in some settings. So in some settings, serotype replacement may threaten to undermine public health gains of PCV, and this seems to vary geographically. So for example, this is in the UK, you can see an increase in non-vaccine serotype IPD following PCV13 introduction, and the non-PCV13 types are the orange line on this chart, and you can see that increase, particularly in those over 65. Whereas in contrast, in the US, the incidence of non-vaccine type IPD remained stable. So these are obviously two developed countries with good surveillance, and they're able to identify cases of invasive disease. But monitoring serotype replacement disease is a critical gap in many parts of the world in low-income settings. So in settings where it's challenging to monitor IPD directly, carriage studies can be a practical way to monitor circulating serotypes. But the role of carriage studies in evaluating vaccine impact and monitoring serotype replacement still needs to be determined. So back in 2011, the PRIME study provided early insights into the impact of PCV7 on pneumococcal carriage. But PRIME really focused on the differential impact of a 2+1 schedule versus a 3+0 on reducing vaccine serotype carriage. And no studies of PCV10 or PCV13 were included. And since that time, serotype replacement has led to a transition from PCV7, and now most countries are using PCV10 or PCV13. So the distribution of serotypes will have changed considerably since the time of PRIME. So while carriage studies provide helpful information on the impact of PCV on circulating serotypes of pneumococcus, it's obviously the impact on pneumococcal disease that policymakers need to know. And some modelling studies have shown that carriage can be used to predict IPD trends. So this is regression models using pre-PCV IPD data in England and Wales, and changes in vaccine serotype carriage pre and post PCV introduction to estimate the impact of PCV on overall IPD. And similarly, using carriage data, these dynamic models have predicted PCV impact on disease. So this shows the cumulative cases of pneumococcal disease averted. This is modeled using data from Kilifi in Kenya. So the critical piece of information that can be added by carriage studies to accurately model PCV impact on disease is the composition of replacement carriage serotypes in each setting in the post-PCV era. So in addition to the impact on carriage and disease, vaccines have the potential to reduce antimicrobial resistance. So PCVs can reduce antibiotic resistance in two ways. So firstly, through direct reductions in vaccine type carriage and disease. And we know that the vaccine serotypes are the ones that are more likely to carry resistance than non-vaccine serotypes. And secondly, through reductions in infections, reducing the need for antibiotics and that driver of antimicrobial resistance. However, since resistance is associated with antibiotic pressure on the carried strains, initial reductions in resistance due to reductions in vaccine type carriage are often counteracted by rising resistance in non-vaccine types. So these, the charts here show carriage of pneumococcus resistant to various antibiotics. This is data from Israel, and you can see the reduction in resistant organisms following PCV 7 and 13 introduction. But that subsequent rise, if you look at the top charts in resistance to penicillin. So this is a global pneumococcal systematic review aiming to describe the impact of PCV programs on serotype-specific carriage and penicillin non-susceptibility. And we'll also compare our carriage results with IPD in the post-PCV era, and that's really a key component of this work. So the review should help define the role of carriage studies in measuring PCV impact and monitoring serotype replacement, and further our understanding of the value of carriage as a serotype monitoring tool. And importantly, it will provide information for us to better understand whether differences in serotype replacement carriage can account for differences in serotype replacement disease that are observed in different settings. So I'll go over the methods of this work briefly. So the protocol is registered on Prospero. A systematic search was conducted of 6 databases to identify all studies published post-PCV assessing serotype-specific pneumococcal carriage, and studies reporting serotype-specific nasopharyngeal pneumococcal carriage that have been performed in countries that had introduced PCV were eligible for inclusion if they also contained individual level data, or those individual level data were available on request from the authors. So we excluded reviews, we excluded randomized controlled trials because we're interested in the population level effects. And the lab methods were also assessed, and studies deemed to have inadequate pneumococcal detection methods were excluded. So duplicates were removed, and 2 reviewers independently screened the articles by title, abstract, and full text, and a 3rd reviewer arbitrated any discrepancies. And as a list here of most of the study details that were extracted from the papers. And we also used ViewHub, which some of you may know provides modeled data on vaccines and vaccine preventable diseases by country. That was used to supplement the available data that was not provided in the articles. So following, so these microbiological data were also extracted, listed there, and all authors were also contacted to provide additional age-specific and serotype-specific carriage data if they had those data available and were willing to share. So if the data were available, studies and data sets will be stratified by age group, by study site, by vaccine program characteristics, by study population, and by prior antibiotic use. And the mixed effects logistic regression will be used to assess the impact of PCV on the binary outcome of carriage. And the exposure of interest will be the years since the introduction of PCV. So this is our PRISMA flowchart. So the initial searches identified 4,076 articles. After exclusion of those that didn't meet eligibility criteria, another 77 were excluded based on the microbiological assessment. And 379 articles were included. So at this stage, we've extracted aggregate data from those included studies, and 78 author groups have shared individual level data with us. So we're currently working to harmonize the shared data sets in preparation for the analysis, so that harmonizing those data sets and combining them for the analysis. That's a huge amount of work, and Dr. Ellen O'Neill is doing most of that work. Unfortunately, she can't be here today, otherwise she'd be presenting this with me. So at this stage, we don't have a lot of results to share with you. This is really a taster, and next time we meet, we should have those results to share. At this stage, I can say the included studies were from all WHO regions with a spread across all income groups, although, you know, as we've been hearing several times this week, the majority of the data is from high and some middle income countries, with less data from the lowest income settings. So in summary, this review of carriage, excuse me, pre and post PCV should help define the role of carriage in assessing PCV impact and serotype replacement. And it should further our understanding of the value of carriage as a serotype monitoring tool. It's expected that the study should be broadly generalizable across regions and income groups. And importantly, I touched on this before, but the results will be comparable with the P7AIDS study, which is another WHO-supported systematic review, similar to this one, but assessing the impact of PCV introduction on invasive pneumococcal disease. And that comparison of their work looking at the impact of PCV on invasive pneumococcal disease with this looking at the impact of PCV on carriage will really be key to interpreting the results of this work. So I will stop there, but just to thank our team, especially Nicole Wong, who did most of the work setting up this project, and Ellen O'Neill, who I've mentioned is doing a huge amount of work with the databases, and to the technical advisory group who've overseen the development of this project and the work to date, and our partners and collaborators in the WHO for their support for this work. Thank you.
Fantastic. Thanks very much, John. So we have some time now for some questions, and I think we have both Stephen and Willie online. So hopefully they can join us. Claire, is Dr. Matt on screen? So I don't know, Gus, if we could bring those up on screen.
I think I'm on screen.
Fantastic. So Willie, maybe I'll start off with the first question to you and then invite questions from the floor. I was very interested in your kind of reflections. So maybe on what a sustainable surveillance system looks like in PNG. And clearly it's something you've been doing a lot of thinking about with your kind of new initiative and centre. And you mentioned the importance of funding, and I know a lot of people in the room are really struggling to kind of, get funding to support surveillance in their countries. So just interested in your reflections on how you've thought about that within Papua New Guinea.
All right, thank you. So the government of Papua New Guinea has what it calls the PAP program, which can support various things. And obviously for us, that's a target for us to try and delve into. Can you hear me?
Yep, all good.
Sorry. Yeah, to try and delve into it. And doctors notoriously, probably notorious is the wrong word, but have the power to be able to convince our members of parliament to provide funding for these sort of things. So if we went to all the provinces and told the chief medical doctors in those hospitals to say this is the type of system that we want to build, and therefore this is the outcome that it will bring for us, I think that we can leverage the type of money that will then help us to make sure that we sustain the laboratory capacity that we built and then make it even better than it has been. So I think it's possible for us to do that internally first. And if we can't do that internally, then we come to our regional partners to see if they can assist us to maintain these systems. I hope that answers your question.
Thank you, Professor Paman. And just a reminder for those online, if you have any questions, pop them into the Q&A chat. But I'll see if anyone in the audience has a question for our speakers. Yep.
Yeah, this is a question for Jonathan, actually. Just around your MATE project. So yeah, it's great to see that coming through. I was interested about your serotype 3 data, you know, pre and or the change from the schedules, and I was just wondering whether that's an age thing. I was wondering what the ages of your children in the study were, because is it, you know, are they older age and therefore the, you know, whatever vaccine effect might be happening with the change in the 2+1 is not, you know, a feature?
Yeah, so the median age in our study was 2.4 years of age. Of the other study, I can't quite remember off the top of my head exactly, but it wasn't significantly different from what we're seeing in our cohort.
Yeah, okay, that's interesting.
And I guess numbers a bit small to look at kind of differences with age distribution and serotypes, but hopefully that will kind of emerge with a bigger data set.
Time since vaccination, you know, for effect.
Yeah. Thanks, Paul. Maybe while the people in the room are thinking of extra questions, Stephen, I was wondering, you know, obviously, you know, a lot of our collaborators are thinking about, you know, ongoing surveillance, and genomics is one approach, but there are also other methods to identify and serotype the pneumococcus. So I guess I was just interested in, you know, what kind of systems do you think need to be in place for whole genome sequencing to be, you know, possible and useful and kind of integrated into public health decision making?
That's a pretty tough question. So if we followed my sort of recommendation from before, that we actually use carriage surveillance and deep sequencing of carriage surveillance, then that obviously requires an ability to conduct a carriage survey. So you would need obviously the personnel and resources to collect those samples. And I think we need to figure out what the frequency of those surveys needs to be, and maybe John could comment on that. But I wonder whether to do it systematically, we should be thinking about doing those kinds of surveys twice yearly, perhaps in a sort of seasonal balance. We've got to figure out what size that needs to be relative to the population of the country. And I think one of the advantages of the deep sequencing approach is that we can simplify the microbiology somewhat, because you're not going for single colonies, so you need to just scrape a plate. And then other infrastructure, obviously you need sequencing resources. So those are increasingly available. And going back to the question that we were just talking about with funding for surveillance, I think it's a bit like jumping on a bandwagon, but there is a lot of interest in funding genomic surveillance. So if you can actually incorporate that into your surveillance system, then that could actually give you a bit of a leg up in terms of supporting your general surveillance systems. But obviously that does require infrastructure enough to be able to accommodate a sequencing machine. And then obviously the final point is that you need capacity for actually analysis locally, which may or may not be available. And as I was saying, there's lots of funding, training resources available now. So
yeah, I think really important, Stephen. So we've got a question from Fiona down the front, and then after that I might ask John a couple of questions building on what Stephen and some other thoughts.
Yeah, just to follow on from that question is regarding the population to actually select for the carriage survey. So we've been doing this within MCRI for a very long time. We've done carriage surveillance, hospital-based carriage surveillance. We've done community surveys, and the people end up in hospital. As we all know, that carriage is incredibly common, but in the vast majority of children don't get sick from that, but are healthy carriers. And so, how to identify the right population and what's circulating in the community might be one thing, but it's not causing disease. So there's still, to somewhat an issue of, and then you've got the hospital-based population whereby their carriage may be influenced by obviously the disease they've got, but also whether they've had antibiotics and other things as well, and a select population, because only those that access care may be quite different from those out in the community. So I think from an epidemiological point of view, we don't know yet what the right population to sample is. And we've done some of that work with Willie, actually, in Papua New Guinea, where we have collected sort of samples from hospitals, from communities and villages over time. But we hope, with your advice, Stephen, maybe if we stick genomics in there, we might get some funding to actually analyse the samples.
That's great. So maybe, John, that were the kind of the two things that I thought maybe you'd want to reflect on, sort of, Stephen's point about the frequency of surveys, and then Fiona's point about, healthy versus, pneumonia, carriage, and what the kind of data you might need for those decisions.
Yeah, I think it's a really tricky question, isn't it? I think from our review, we hope to get a good understanding of whether the carriage data is a good reflection of the invasive pneumococcal disease data. And then there's really those questions of whether we need to be collecting this regularly in the community, or it should be cases of invasive disease. I think there's a lot of work that still needs to be done in that area. So yeah, I don't have much more to add on that.
Yeah. Okay, thanks, John. Dr. Lay, and then Sam.
So thank you for the talk for Stephen and Jonathan. I have two questions. One question is, Stephen, you mentioned about the serotype 1 when the carriage rate is very low, and if you appear always like a minor population, like 1%. So I wonder the situation of serotype 3 in that case, from your perspective, how's the situation of carriage of serotype 3 in the children or in the older, adults or older age group? Do you find as a minor populations? Because usually when we do carriage survey, serotype 3 is very, small number. Usually we detect in children. But here in Australia, you are mentioning that the median age was, 2.4 years, and empyema case was causing 5% of. That's, alarming. I just wonder whether the carriage in the general population in Australia, whether there is different in time of serotype 3. Or does this serotype 3 only particularly cause empyema? Do you also see similar rate in the meningitis or, bloodstream infection cases, or it's more invasive inside the lung? That's my question.
So maybe we'll go to Stephen and then Jonathan, just to have a quick reflection on that.
Yeah, so I'm afraid off the top of my head, I can't recall the data on serotype 3, but that was a carriage study in the refugee camp on the Thai-Burmese border, and I don't have in my head the prevalence of serotype 3 in that community and how it looked in that deep sequencing data. So from my recollections, serotype 1 and serotype 5 were definitely following those characteristics of being present as minor variants. But I can't remember serotype 3, but maybe also follows that pattern.
So we might just get Jonathan to comment on kind of our swabs and looking into some of those questions.
Yes, thanks for the question. Yeah, so I should clarify the incidence rate of 5%. That's globally, not in Australia. In Australia, it's a bit lower than that. But we are collecting swabs where we can from patients to be able to look at nasopharyngeal carriage of pneumococcal serotype to determine if serotype 3 is very prevalent there too. Clearly, it's very prevalent in causing disease, but whether it's actually as common in carriage, we don't have that data just yet, but we're looking to collect that.
Yeah, great. Thank you, Leigh. Great questions. So we might just pass over to Sam, Dr. Sam Manor.
Thanks. My question was actually very similar along the lines of Dr. Leigh's there. I think about how a lot of these invasive serotypes like 1 and 3, they seem to be quite rare in carriage. So kind of speaking to John's work about, using carriage as a proxy, just kind of, I guess, be keen to get your thoughts about looking at it as well at the serotype level. If you're wanting to look at, trying to use it as a proxy for looking at serotype replacement as well, if some of those replacement serotypes then tend to be rare in carriage, but obviously become a problem in disease. Just keen to get your thoughts on that.
Well, I think it's a really important point, and it's a key part of this work to try and understand how well carriage can predict invasive disease. And if it can't, then this carriage work will be of less importance in some areas. If it's just for specific serotypes, as it may be for these, we're talking 1 and 3, then it may be of less use for those.
Thanks. And I guess, it might vary a bit by site. So we've used microarray, which is also pretty sensitive at detecting minor serotypes, and haven't really found evidence for kind of invasive serotypes, hiding as kind of minor serotypes. So whether that's, it's not quite sensitive enough as the deep sequencing, or whether it varies by location, not sure. And obviously we'll have a bit more of a dig around in that data because it might also vary a bit by serotype. Yeah, so I think there's kind of lots of complexities that'll emerge in the future. I think we have time for one question. We had one in the chat, so maybe Anjana, do you want to? Okay, you think it's covered? Okay, we think it's covered. So maybe just to wrap up, Lisa, sorry? I think it's covered. Yeah, thanks, Claire. So I think just to finalize, Elisa, maybe your thoughts on kind of how your findings and projects might, I guess, relate to kind of the WHO approach. So, pleural fluids, it's not a super common, empyema is not super common, but the sample's quite, easy to work with and good for molecular testing, and it's an invasive pneumococcal disease. But obviously the low culture positivity means that, there's not a lot of data from empyema cases. So do you think in that context, molecular serotyping and identification might be useful?
Yeah, I think it's the way to go from the moment that the culture is negative. So molecular techniques are very sensitive as well. As you mentioned, the pleural fluid is coming as the standard procedure. So the trains on infected pleural fluid is available. So it can be used. It will be a useful tool for the future for gathering information, serotype data. And as I mentioned in the talk, that if we have data from serotype data from the pleural fluid, typically has a broader presentation of the serotype circulating in the area for other pneumococcal syndromes. So we gather very important information.
Thank you. And I guess I was just reflecting back on Fiona's opening remarks to our CRE about kind of evidence gaps. And certainly our initial data is that the positivity rate for pneumococcus is worse than other pathogens. So potentially we're kind of getting a skewed picture of the etiology by using culture-based methods and underestimating the burden of pneumococcal disease. So I think we're running into our morning tea break, but just before I close the session, just a couple of reminders. One is, again, at 11 a.m. there'll be a minute's silence. And we have a fantastic session after morning tea on vaccines with Professors Kim Mulholland and Anna Ong Lim chairing. So I think that will be one not to miss. So that'll be in about 15 minutes time. And also a reminder that we've got quite a late lunch break today. So in your morning tea, make sure you eat lots and fuel yourself up for what'll be a fantastic session when we come back. So thanks to all our speakers and to you all.